Hi, my name is Cesar Garcia. It's my pleasure to speak to the Maine Nursing Home Association about lowering the fall risk in long-term care. In the United States, there are 1.5 falls per bed per year in nursing homes because of clients' age, morbidity, and frailty. I'll speak about research that addresses this. In this presentation, I will recommend number one, 3 fall risk screening tools. Second, 4 multifactorial assessments provide nurses with a list of risk factors ranked by predictive power. Number 3, manage the screening tool sensitivity and specificity. The stages in the fall risk program are marked with a target symbol on the PowerPoint slide. Investigators stress that for their screening tool to work, it must be matched to patients. I recommend the 3 studies presented today and suggest an in-depth description of number 1, medical profiles, number 2, the ratio of acute to long-term care beds, number 3, the patient facility design, and 4th, details of interventions used. A study by Morse in Canada was in an urban hospital. Geriatric long-term care beds and veterans home beds were included with acute care cases. 6 risk factors yielded predictive power. Risk factors were scaled in a range. The screening took 1 minute, the sensitivity was 78%, specificity 83%. My second study is the St. Thomas Risk Assessment Tool in falling elderly, stratified. It was in 3 London elderly care hospital units. Mean age was 80. With underlying disabilities, patients had acute illness. The average length of stay was 13 days. 5 risk factors yielded protective power and were scored 0 or 1. Screening time was 1 minute, sensitivity 92, specificity 68. My third study is the Mobility Interaction Fall Chart. It was a Swedish residential care facility. Patients' mean age was 82, 72% were female. Living arrangements included either a private room or apartment or a unit for people with dementia. After screens for mental status and ADLs, clients went through a motor and sensory task-based algorithm. Screening time was 5 to 15 minutes, sensitivity 85, specificity 82. There are over 600 medical risk factors in the elderlies for fall. Researchers have quantified their predictive power and tabulated them. After a positive high risk score, I recommend nurses be provided with an aggregated list of risk factors ranked by predictive power for multifactorial risk assessment. Henrique listed the predictive power of fall risk factors. Rubenstein ranked risk factors by their predictive power. The screening tool should be monitored periodically to manage sensitivity and specificity. This can be done with a 2x2 table. Program performance and cost may require adjusting the tool sensitivity and specificity. This is a table of scores for Morse's tool. It shows 4 people with a score of 25. People scoring less than 25 represented 20% of patients. If the program head increased the threshold score to 30, an additional 3.2% would not classify as high risk. This table shows operating costs for a fall risk program. The first row, labeled Cost 1, is in a blue rectangle. It is represented in this slide in a 2x2 table. The zeros are accurate predictions of falls and no falls. -10 is the operating cost of a false negative, a person not classified high risk who fell. -50 and 100 are higher costs. The last entry in each row is -1, which represents the cost for a client who screened high risk but didn't fall. This diagram shows how the threshold for high risk scores affects program costs. Starting with the blue rectangle, when the cost of a false negative is -10, the lowest program cost is at a score of 35. With higher costs for false negatives, like -50 or -100, the lowest program costs are at scores of 25, and 0, respectively. For a 0 score, all residents are managed at high risk. So my recommendations are: number 1, 3 fall risk screening tools. Number 2, for multifactorial assessments, provide nurses a list of risk factors ranked by predictive power. And last, manage the screening tool sensitivity and specificity. Thank you very much.